7:34, we will get started with today's session. We have a pretty thin attendance today. We'll carry along as more people join. Good evening all to the Weekly Huddle. My name is Anup Agrawal. I am an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for the Huddle, Dr. Praneeth Palamari. The Huddle is an unscripted, audience-level interaction where we address common clinical scenarios like the topic that we have chosen today. We aim to keep the discussion very practice oriented. In a sense, we pick one particular topic and a clinical case, and we try to restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussion to a more organized platform like this one and share our ideas. While we welcome science and guidelines, we intend to help a physician translate what is established knowledge to more of a clinical practice, taking local factors and practice patterns into account. We host this session every Wednesday at 7:30 p.m., typically end up starting a few minutes late. This is our 35th session. And today we are going to talk about stable angina and management decisions around it. This is kind of an Achilles heel for cardiologists. There's a lot of contention about role of revascularization in stable angina. And I do realize that most of the cardiologists don't feel comfortable talking about it because our practice patterns and our thought process, they sometimes don't align. And that is something we'll try to highlight a little bit and hopefully try to get a meaningful discussion on this. This is not a speaker and audience model, rather an audience level interaction, which means if any of the attendees have anything to add, they can simply raise their hand or unmute themselves to give their input. As a courtesy, you should wait for others to finish their thoughts before you unmute yourself. Having said that, I'm going to start with a clinical case for today. I will ask my co-host Praneeth to give his initial input. Then we will open it for discussion amongst our attendees. So Praneeth, this patient I saw, I believe 6 weeks, 8 weeks back. He's a 58-year-old male. He's a government employee. He took an early retirement. He was diagnosed with hypertension and diabetes around 2 years ago at the time when he went for a routine checkup. He is currently taking medications for the same. He is on telmisartan hydrochlorothiazide combination for hypertension, and he takes 1000 milligrams of metformin for diabetes. Those are the only two medications he's on. He is an ex-smoker. He used to smoke during his college days, but currently he's fine. He came to me rather primarily because of some chest discomfort associated with dyspnea on exertion. This he started noticing around 3 months ago, and it really doesn't interfere with his lifestyle, but he has started noticing it, which he didn't have it before. He otherwise is able to do his routine activity, and these symptoms also come after walking for about 5 to 10 minutes or so. And sometimes when he climbs stairs, he otherwise does not have any resting symptoms. He feels fine. Once the discomfort appears, he takes rest, and within 2 to 5 minutes, the symptoms disappear, and then he can carry on with his activity again. For 3 months, he didn't seek any medical attention. This time, his daughter is visiting him, and on his daughter's insistence, he came to me for further investigation. He does not report any other medical problem. On his clinic visit, his blood pressure was noted to be 160/90. Heart rate is in 80s. Rest of the examination in normal limits. He is a moderately built guy, little bit overweight, but okay. His basic lab investigations, including ECG and echocardiogram, had been normal. Now, based upon history, which was very typical of angina, and he's at the age group with the kind of disease which are established risk factors, I offered him to go for coronary angiogram directly to establish the burden of disease. In the meantime, I also put him on anti-anginals. I took telmisartan and hydrochlorothiazide away. I put him on beta blocker and vasodilator drugs. And I told him to come back for angiogram. which he took about 2 weeks to come back because he had to get some letter and whatnot, and some amount of I would consider laziness as well. So he came after 2 weeks to my cath lab. Tells me that doc, the medicines you gave me is working well. My symptoms are more or less gone. Now I am able to for about 20-25 minutes without any discomfort. I am taking all the medications regularly. My blood pressure at home ranges around 130s or so. So we did an angiogram and we identified that he has a mid LED lesion, which angiographically I classified as about 80% stenosis. It was a short segment lesion, which was relatively easy to fix. So we got this patient off the table and we started discussing about what to do with this single vessel 80% stenosis. His rest of the coronary vasculature had only mild disease, nothing major. So Praneeth, my question to you here is, and this is the question that I put up in the discussion, in the invitation as well. The questions are, this patient who came to me 2 weeks before this angiogram with classic angina with no any unstable symptoms. He is responding well to medical management. His symptoms are gone now. His blood pressure is controlled. He has got a mid LED lesion. Should we continue medical management at this point, or should we stent? That is question number one. Question number two, if we don't have our decision made on this, is there stress test in this situation? If there is, which one we should do? Any other ancillary tool that you can address to help with the decision making? And lastly, this patient heard somewhere that EECP can treat coronary artery disease without stent or without bypass surgery. So I put EECP there just as a part of discussion. EECP is external enhanced counterpulsation, which is used for angina. So Praneeth, what would be your initial impression? This guy is at cath lab. Let's say if you are the one making decision, what would you offer and why?
Good evening, everyone. Thanks enough for that case. So, how would I look at this patient? Relatively young person with reasonable productivity and 58, so I think has active life, so to speak, and has angina class 2-3, stable ischemic heart disease with factors. So, as you rightly said, first would be to control his risk factors and optimize his medications, and now feeling better about the decision making about revascularization. I would prefer to revascularize him. Yes, medicines seem to be working, but medical management, revascularization or offering him better benefit of freedom from improvement in quality of life, and that we medicines, everything will be better than what medicines are already offering him. So I would go ahead or advise him to undergo revascularization. And because I made the decision to revascularize, I would not be uh, requiring any more stress testing or anything unless there is a decision comes to justify my decision of revascularization. And regarding the role of EECP, and actually that EECP is mostly combined with that chelation therapy in the centers. Uh, Not proven chelation therapy does. Regarding EECP is indicated in refractory angina where you are not able to revascularize small vessel disease or diffuse disease where you are not able with intervention or revascularization having limiting angina. That is where they may be helpful. For this patient, EECP has no role. So that would be my take on it. Him to undergo PCI because it's in mid-LED lesion, easy to fix, so procedurally, so the advantages are more compared to the risks involved. My take would be to advise PCI in this patient.
Thank you, Praneeth. And may I request you, your voice was breaking a little bit. Maybe you are using a different internet where the bandwidth is a bit weak. If you could just rejoin using a more stronger internet while I continue my discussion with other colleagues here. Dr. Johan, are you able to hear me? Welcome back on the huddle.
Yes, Anup.
Dr. Johan, were you able to follow the clinical case that I described?
Yes, partly.
Yeah, so this is a 58-year-old guy with angina whom we started on anti-anginal therapy. His symptoms got better. We did angiogram on him. He has a mid-LAD lesion, and we are now sitting discussing about what should be done next. So if you were the treating physician, what would you advise? It's a 80% mid-LAD short segment lesion, easy to fix. It's going to be a stage intervention if you do advise intervention to him. So he is to go home. Whether you want to continue medical therapy because it's working, or whether you want to advise him intervention, or whether you want to do some sort of ancillary investigation to further answer your question in form of stress test or something else. How would you take this case, Dr. Jahan?
Yeah, Anup, this patient is obviously stable. He's a stable CAD. There's no ACS. He's responded well to your medication. It's a mid-LAD lesion. There is no left main ostial LAD or a triple vessel. So medication, as you've seen in the ischemia trial, has worked. It has worked as well as PCI. PCI has scored in the subset wherein the angina wasn't controlled. And since we had a good number of patients ourselves, they did exactly similar. What I would do is I would still, after medical therapy, I would put him on a stress maybe and look at the extent of ischemia. And if the ischemia is less than 10%, it would be justifiable for me to continue on medication, provided he's compliant with medications and is easy to reach out to. If it was more than 10% on the MIBI, I would, because of the benefit risk ratio in favor, I would go ahead and do the stenting. So that would be my approach.
Okay, there may be some issue with my connection as well. Am I audible? If somebody could verify.
Yes, very audible.
Yeah, so Dr. Johan, I missed part of your discussion partly because either my internet was weak or yours was weak. I got about your ischemia trial. If it is not a left main or ostial LAD lesion, then these patients, they did well, in fact, very well with medications. My only, while I'm a very firm believer of evidence-based medicine and the research that is carried away, my biggest contention with translating these research to common clinical practice is that whenever we are comparing intervention with medical therapy in a randomized fashion, particularly in a well-designed research study, there the medication arm or the conservative arm is very well controlled with a very good follow-up, with a one-to-one kind of a patient level interaction where there is a research coordinator who is making sure things are working in a perfect order. And if anything we know about human beings, that we really don't follow perfect order. Maintaining blood pressure medications, maintaining daily exercise regimen and whatnot, where the onus lies on the patient, most of us, when we are also patients, we don't do very well. We want to get things fixed so that we have the flexibility of being kind of ignorant or lazy about our responsibility for medical care. So that is one of the biggest contention that I have whenever I try to translate a good randomized clinical trial into medical practice. Patients in clinical trial, they don't get pneumonia, they don't get UTI because they are not followed. They get excluded or they don't get analyzed. And here we have got patients with some degree of ischemic burden, whom we put them on medical therapy, and they end up getting, or some of them may get a stressed reaction for something, infection, whatnot, and that may translate into worsening angina or worsening coronary disease. So I'm not advocating going for intervention in all the cases. I'm just trying to keep the balance in the discussion on both the fronts. so that we have enough of points to discuss. So that was my point of kind of analyzing these randomized trials as far as their practicability is concerned. So I hear you, Dr. Johan. Will get back to you. I'm going to ask other people their thoughts. Ravi, Dr. Ravi was a junior consultant here with us. He left care just a few days ago. Dr. Ravi, if you could, if you're able to hear me, please unmute yourself and tell your thoughts about how you would manage this patient.
Yes, sir. As the Dr. Johan sir said, I will go with the same strategy as patient is doing well and he is able to do whatever the activity he wants to do on medical management. I will continue the same and to reach like it was if it was ostial or proximal LED, decision would have been much easier as it is a mid LED lesion. We can identify ischemic burden on stress thallium and depending on that percentage, we can go for intervention if it is a high ischemic burden. And as you are talking about the compliance and other things, as you said that in research trials, they follow very sincerely. The same thing will be affecting after stent also. So if some patient is having less chances of complying with the medication, then after stent also he is less likely to follow the medication in the form of antiplatelet and statin. So that decision will be pretty dicey. So I think if I'm going for a stent, I will make sure that it is absolutely indicated and patient is going to have some benefit from that. That's all from my side.
Yeah, Ravi, I could hear you. I think we are having a problem with Anup's network. Yeah, so
Yes, sir.
point taken about middle AD lesion, evaluating about the ischemic burden more in terms of lines in terms of what Dr. Johan said. We'll take few more comments and then probably we can come back again discussing and probably debating. We'll take comments from Srinivas Raju sir. Srinivas Raju sir, how would you approach this case or how would you manage? What would be your take on this thing?
Yes, Dr. Praneeth, this patient is 58-year-old and is a government employee who is retired, right? So probably if he is not likely to get reimbursed and if he is not going to buy medicines on his own, but if he is willing to go for a procedure, we can still offer a procedure for him in the form of PCI, because if it is a calcified plaque, even though you give a high dose of statins, the plaque is less likely to regress if it is a calcified plaque. And even your FAME2 trial showed that if the FFR is less than 0.8, even though if it is a middle AD lesion, the primary events are less as compared to the medical therapy. So even though if it is not a left main disease or a multivessel disease, still we can offer him PCI.
Sure, sir. Point accepted. Uh, we'll move forward, sir. We have Praveen Nagula, who is an assistant professor in Usmania currently. Praveen, what are your thoughts on this? If you can unmute yourself and share your comments.
Hello, good evening, everyone. Sir, considering this patient, I would go with medical management, sir. I would be observing him on follow-up, and if the patient is being symptomatic even on the medical management, the maximum dose which he could tolerate, and then I would take a call of taking the patient for PTCA. And regarding the EECP, what you call only if the patient is having refractory angina and you have done all types of modality of treatment, then only the role of EECP would be beneficial. And considering our Indian scenario, the patients who underwent EECP because of the vibrations that they cause for each procedure taking around 40-45 minutes, and the noise, most of them will not be accepting for that particular treatment. And regarding the any stress test. Of course, if the patient is symptomatic even on the follow-up, I would go with perfusion scanning, and then I will be taking the call regarding the management. Hello, sir. Am I audible,
Yeah.
sir?
Yes, Praveen. We could hear you. So you are also basically advocating more of a conservative approach than an aggressive approach. I hear you. We'll take comment from Shankar sir. Sir, how would you look into it? Shankar sir is our senior physician, kind of a regular attendee to Huddle. Sir, how would you look into it right now? We heard from most of the cardiologists from a physician's perspective. How would you approach this case, sir? Shankar sir, if you could unmute yourself. I think, yeah, yes, sir.
Good evening to all. I thank Dr. Anup Agarwal and Dr. Praneeth for conducting educative huddle every week. And regards to my teacher, respected Dr. B. Somarazu, for his expert comments in each huddle. This is actually this is beyond my purview. But as far as my knowledge goes, I prefer PTCA followed by stenting, drug-eluting stenting, with associated with the optimal medical therapy, pharmacological therapy plus lifestyle interventions. This is beyond this. I cannot comment on this because this is my opinion. Thank you.
Yes, sir. Thank you for that. Thank you for that comment, sir. So, my argument or my point of going ahead on intervention is, again, the way I am looking at is how complex is the lesion and how can we fix the issue clearly. And as Anup was highlighting previously in his previous comment about any untoward stress on the heart in the form of an intercurrent illness or some anemia or whatever, then that ability to handle that stress of ischemia, as long as the patient is stable, it's fine. But when he has an undue stress in the form of other things, and then I don't want to have any regret of not doing this thing. And equally, how complex is the lesion and how equally can it fix it? Versus if it is too complex of an issue, I would have been hesitant in doing an intervention. And the point which Dr. Ravi also mentioned was very valid, ensuring the drug compliance of the patient, where I make sure that the patient does take the dual antiplatelet therapy, and only then I would be happy to put in a stent. And I don't want to end up having a stent thrombosis where the patient is not compliant with the dual antiplatelet therapy. And because there were more of favorable points in terms of doing an intervention, and all said and done, though it is not statistically significant, where PCI was better than medical management in the so-called courage orbita or even the ischemia trial, but definitely it is better compared to medical therapies when revascularization is considered. So I would tend to favor revascularization more, provided I can do the job easy enough without producing much of an issue. That would be my take on it. Any other suggestions or questions are equally welcome.
Dr. Chandramukhi has joined us. Dr. Chandramukhi, if you could unmute yourself, we would like to get your thoughts on this case. I'll brief you. This patient is a 58-year-old guy with stable angina pectoris, not on any anti-anginal medication, who comes to the OPD with high blood pressure. He's put on anti-anginal therapy, which relieves his angina. He's feeling better. An angiogram is done, which shows mid-LAD 80% stenosis. He's otherwise feeling okay, and you are in discussion of what to do with this 80% stenosis. The questions are medical therapy versus PTCA. And the second question is there any other ancillary test that you would advise to this patient? to help with the decision making in case if your decision is not made yet. I'm talking in terms of stress test versus any other test. So Chandramukhi ma'am, how would you take this case, angioplasty versus medical therapy and others?
Good evening all. Anup, whether this patient is a diabetic?
This patient was diagnosed diabetes 2 years ago on metformin 1000 milligrams, which is taking care of his diabetes right now.
Yeah, I would like to do revascularization in this patient, like a PTCA with stent to LAD.
And ma'am, why is that? We had before you joined Dr. Johan and Dr. Praveen, they both suggested that it's a mid-LAD stable lesion. Why to touch when the symptoms are already better with medications? How do you defend your decision?
Only plain angiography, it will not tell us about the nature of the lesion. In few cases, even after we have seen that even after we do treadmill test is negative and patient comes with MI after about 2-3 months. So in such cases, the vulnerable plaque may be the culprit in these cases. So only angiography will not tell us the nature of the lesion. So if any other modalities are there to know the nature of the lesion, whether the plaque is vulnerable or like that, then I will be comfortable to decide whether this patient should be managed medically or we can like PTC is feasible in this case. And again, one more point to tell us that if we take help of OCT or these things, imaging modalities to assess the nature of the lesion, these modalities itself are very costly. So if I will make sure, as Pranit has already pointed out, that we have to make sure that the patient will be taking drugs regularly, and then I will be preferring PTCA in this patient.
Thank you so much, ma'am, for your comments. We have Dr. Shirang with us. Dr. Shirang, are you able to hear me?
Yes.
Yep. Okay. So, Dr. Shirang, this is a hardcore cardiology discussion we are having, but I would like to get your opinion on this. I'll brief you with the clinical case. A 58-year-old guy with angina, which is now relieved on medical therapy, he continues to take medications. He underwent an angiogram where the cardiologist says that he has got a mid-LAD 80% stenosis. And you are part of the discussion about whether it should be stented or not. What would be your take on it based upon your information? And I have a follow-up question on your take, but first, if you could just give us your impression on this case.
I would want to find out during the angio was any FFR done to know whether that hemodynamically significant stenosis is there.
So during angiogram, FFR was not done. It was a plain diagnostic angiography.
Although stabilized on medical management, we need to know how the person would progress. And I would like to know the consequences either by non-invasive testing or an FFR to proceed regarding the decision to either do a stenting or then just continue the medical management.
And when we talk about FFR, then there is this obvious concern of wiring an artery with the potential associated with that wiring, because FFR is kind of entering into the territory of intervention. Is that something that you are comfortable with for lesion assessment, or you would think we should do it in a selective subset of patients? Let's say this patient, for example.
Yeah, especially when you're not very sure patient is symptom free, whether that stenosis is to really tell it is significant during the same sitting as the angio, we would prefer to do it. Otherwise, non-invasive testing, even a stress thallium would help us to know whether that territory is involved.
Perfect. Thank you so much. Dr. Johan, I'm going to ask you one question. In fact, I'm going to ask you two questions very, very directly. If you can please unmute yourself. Dr. Johan, you are able to hear me?
Yes, Anup.
Yeah. So my question number one to you is, if 10 such cases appear in 10 different cath labs, how many of them you think will get stenting in India?
Anup, am I audible?
Yes, sir, you are audible. Am I audible?
Yeah, you're a little faint, but I would say in about 8 of the cath labs, he would get stented.
My question number two is, if 10 of these cases are being discussed in academic meetings, how many of them will say that we will stent it?
Maybe 2 out of 10.
And why do you think that discrepancy is, other than financial incentives?
I thought the financial thing was the main thing on the cards.
So I genuinely believe that it is more to do with just the financial incentive. I used to think that, but I'm going to ask Dr. Somar next. I used to think that most of the decisions that we make, I used to think they're all financially driven, but more and more I'm getting myself convinced that treating physician genuinely believes that the decision he or she is taking is the correct decision. So I genuinely believe that most of the time when we look at the population-wide data, we take it, our decisions are different. It's something like this. If you ask 100 physicians about, and Shankar sir, please correct me if I'm wrong, I have it in one of the psychology classes. If you ask 100 physicians that you see a kid with URI symptoms, how many of them you would prescribe antibiotic? And out of 100, they would say maybe 10 patients would need antibiotic, 90 patients you wouldn't give antibiotic. But if you track those same 100 physicians in their practice using, and if you see the same clinical presentation of kids for which they had been asked question previously, majority of them will prescribe antibiotic. So this whole question comes that when we look at the population-based assessment, we typically have a different opinion, but whenever we are trying to treat that particular patient, we always have a rationale or a reasoning of why we are deviating away from what is the evidence, why is this patient an exception for that particular evidence, or why is this patient does not fit into that population-based study, and trying to defend that not just in angioplasty alone. We see it in a lot of medical scenarios. And I genuinely believe, and I would be happy to be proven wrong. I genuinely believe that a lot of physicians, when we are deciding to intervene or not intervene, many of the times we genuinely believe that we are doing the right decision, not particularly because one angioplasty is going to make more money for the hospital or for oneself. So anyway, that was my naive thought process. If Dr. Somaraju, if I could have your thought on this, and you have been in pioneer in this kind of decision making, as to speak. 58-year-old guy, mid-LAD lesion, easy to intervene, but symptoms are better with medication. Are we done here, or do you think we should do some more? And what do you see in your practice and people around you? What would you advise us, Dr. Somaraju?
Anup, you have chosen an extremely important problem, and then I must congratulate you for having chosen this type of patient problem, and also tell you that when you raise issues like this in a corporate hospital, your job is at stake. Did you hear me?
Yes, sir. Absolutely, I hear you. Absolutely, I hear you. That is why there are no admin in this huddle.
Okay, doesn't matter. Then I must tell you again, coming to the realities. The coronary artery disease is an extremely complex disorder, and it is even more difficult. It's even more difficult to understand than anything else, actually. So to the extent that there are two important concerns in dealing with any coronary artery disease patient, particularly a lesion like you are talking about. Number one, what are the risks of ACI and resulting in a large myocardial infarction and disability and a death, LV dysfunction, one component. Second is unexpected sudden cardiac death. These two issues should bother anyone. And then when you ask these questions, how much of that we can answer with the presently available knowledge is limited. And vulnerability of the plaque, Dr. Somebody talked actually, say it's not it's not easy to know. Then suppose in this patient, particularly diabetic, I would particularly go out of the way if he's on metformin and all, to check for vitamin B12 and say homocysteine and all that, which predispose to acute occlusions, etc. But apart from that, it is very important. I am surprised that nobody asked for wanting to see the angiogram themselves. Many times the patient has angina, the lesion is assessed as 80%. The error in the estimate for each one of us may be as much as 20 to 40%. And then individual variation in lesion assessment is enormous. And then, but suppose this patient, this is the only lesion, no other small vessel disease, a small diagonal tight, or a distal disease in some other vessel. That may explain angina sometimes. This lesion may not be responsible for angina. And then, say, one needs to see the angiogram oneself, and more than one of us have to make these decisions together. And then, while I say this, people who, on the other hand, suppose this is the only lesion, really 80%, and talking about complexity and all that, it's a concentric lesion, 58-year-old person, it's highly unlikely he'll have severe calcification and all that. It will be a simple lesion to dilate and all that. But having said that, the risk of dual antiplatelet therapy for almost lifelong in a diabetic patient versus managing them medically is the issue. And secondly, somebody talked about FFR. FFR is another corporate strategy. Somebody has angina, somebody has only one lesion that is estimated as 80% by more than one of you. FFR to me is misleading. And I agree with Anup, what he talked about. And also many people, when they do an FFR, the angiogram done ad hoc, and before they do angioplasty, this patient was not even on anti-anginal drugs and vasodilators. The very wire stimulates vasospasm, and then FFR will be unreliable. And these issues are not even considered when decisions are made. But anyway, I have some more things to talk about. But I must congratulate you for having taken up this issue. Mind you, coronary artery disease is complex. Again, I'll repeat. And then there is an analogy. We are all the same. We are all different. Each individual patient is different. The decisions have to be individualized and then managed. That's the only thing I can say.
Thank you so much, sir. We will continue with our discussion. And if people don't mind, I'll just share one anecdote. When I was doing my internship in one of the secondary healthcare setup, which were ancillary setup for AIIMS, this was in a small town called Ballavgarh at Haryana. Most of the gynecologists who used to get posted there, they would do hysterectomies left and right. They were doing more hysterectomy. In fact, there were more hysterectomies done in that secondary healthcare setup at Ballavgarh than at the main center of AIIMS. And at that time, we only had one AIIMS. And one time we asked the gynecologist over drinks that, hey, why the hell you guys are making Guinness World Record for hysterectomy? And the person who answered me, that is the answer I'm sharing, whether that has got any relevance or not, but it did stick to my mind at that time, right or wrong. What he said was that the ladies who come at the perimenopausal period, who already has their family complete, whenever they come with bleeding or menorrhagia, we have medications, we have ways by which we can treat them. We have ways by which we can prevent the complications associated. We can do all of that. The problem here is then the patient has to go home and follow all of them. And if anything we know, they don't do it. Survival is far more important than all of these things. And amongst the survival, people have to go to weddings as well. People have to eat whatever they want to as well. Things like lockdown come as well, where they don't walk. And human behavior come in the way between what is to be done for the health and what ends up happening. So what the gynecologist tells me is that we take care of the problem, albeit surgically. Yes, the perioperative morbidity is associated with it, but at a population level, we are able to deal with the disease in a much more efficient way by doing that than shifting the onus to the patient, where now the patient has to take care of all of these, which many of the times, in fact, universally, you would say, patients don't do it. So again, whether that makes any sense or not, but whenever we talk about these chronic illnesses, where what Dr. Somaraju sir was saying is the long-term incidence of sudden cardiac death or ACS, and whenever we are dealing with stable angina, then we have shifted that goalpost. Earlier, we were thinking we are saving lives and we are saving heart attacks. Now we know that stenting in a stable disease doesn't necessarily do so. But it does relieve angina. There is no question about it. The question is whether it relieves angina better than medications or not. And that is on the patients with the trial and all those things. And I think in the practical term, whenever we look at, and this is the whole purpose of discussion like these, where we want people to share what challenges they face practically. This patient who came into my OPD with a blood pressure of 160, who is taking medications for 2 weeks because he is to undergo angina, I am very sure that if I take care of 10 such patients, and I'm sorry I'm being judgmental, about 50% of them, they still will stay with a blood pressure of 160. Many of them will still not check blood pressure at home. Many of them may not take medications the way they are supposed to. Many of them will still take a high salt diet. I won't be surprised if a lot of patients come back to me after 2 months again with the same 160 blood pressure, because that discipline maintaining is a little bit difficult, particularly if you are 58 and you have to maintain it for another 10 years, 15 years, or 20 years, or whatnot. So as an interventionalist, I'm biased because I think that what I can offer to the patient is superior to what patient can do themselves. It's a biased statement, but this is what I believe, and I think this is what most of the interventionalists believe when they advise or when they put intervention at a superior position as compared to medical therapy. Obviously, at a lot of places, a lot of situations, incentives also come into play. So that is my take on why I would intervene on this patient. That is my take on why I would not do any further risk stratification on this patient. If we have a patient who is very good with his medication and who is going to do absolutely what it is supposed to, then mid-LAD lesion like patients like these can be left alone, and really they wouldn't cause much of problem in terms of longevity. But a random Joe that we see in our clinic, I end up offering them more intervention than what ischemia or courage trial would suggest, because of these practical issues that I am sharing. They are not science-based, but that's my thought. So having said that, I would open it to discussion. If anybody has got any thoughts.
Anup, can I add something here?
Sir, yes, sir. Yes, sir, please.
Or the uncertainty of dealing with coronary artery disease and that I would say the glorious uncertainties. If anyone who has an experience of going through all this would remember that you did an angiogram, you said the angiogram is normal, but the patient came back after a week with an acute myocardial infarction, and some of them didn't make it. And with that extreme experience I am talking about, to the lesions we are talking about. Keep all this in mind while making decisions.
Absolutely. And in fact, when we talk about angiogram normal, one also has to understand that a plaque burden has to increase by more than 40% for it to be even visible on the angiogram. And this is universally true. And this is for my non-cardiology colleagues who are here in the attendee, that if somebody has got a plaque burden of less than 40%, there is a very good chance we may not even see it on the angiogram. These lesions are very well seen on the CT scan or very well seen on IVUS or whatnot. That is why the treatment is risk-based, not lesion-based. So if a diabetic patient who is a previous smoker, that patient should be on CAD management regardless of what angiography shows. And that is where the risk assessment and treatment based upon that comes rather than the actual lesion. That is why what Dr. Somaraju was saying, once a while we do see patients with a normal angiogram and within a week or a month come back drop dead with an acute MI. So those things can also occur. Anybody has got any thoughts, any questions, comments about what we are discussing? It's a broad topic, but I did want to address it so that we initiate our thought process onto it. Dr. Prithvi, if you could unmute yourself, you heard the entire discussion that we were having for the past 40 minutes. What is your thoughts? Please feel free to talk about the case or talk about what we are, disease process that we are talking as a general. Dr. Prithvi. Dr. Prithvi, I hope you are able to hear me. Okay, Dr. Shankar, if I can have you again in the meeting. I remember early you said that while this is outside of your forte, you would choose to intervene. A few cardiologists in the meeting, they shared with you their rationale of intervening versus not intervening. Does that stimulate the thought process which you started with? Does it change what you have been thinking so far, Dr. Shankar? Okay, since I'm not getting any response, I have to question, am I audible to people? Am I still online?
Yeah, I can hear you, sir.
You're
Okay.
audible, sir.
Yeah, so maybe we are having problems with the people whom I queried. Praveen, Dr. Praveen, if you could come back and just tell me my rationale of offering intervention in this patient. Do you think it is well founded, or do you think this is based upon my biasness towards intervention?
Sir, okay. I think what you call when we take a decision of a particular patient at that particular point of time, whatever we make a decision. Of course, probably if I see the same patient tomorrow in my OP, I would change my decision and take for PTCA. So I agree with you, sir. So probably I might be discussing this one, but at that point of time when I have seen the same patient and visualizing the angiogram, I would change my decision to PTCA, or again I can just keep the patient on medical management. But what I would say is at that particular point of time, what you call we would be sensing that of course if we stent the lesion, the patient might be benefited. If that process comes into your mind, probably I would what you call cling up onto the intervention. Otherwise, I would go with the medical management, sir. So I agree with you regarding the intervention.
Thank you, Dr. Praveen. Anybody has got any thoughts, comments while I continue to invite other attendees for their thoughts?
Yeah, no.
Yes,
Can
Praveen.
I say something? Yeah. So other practical aspects of looking at is the textbook way of working out a patient and offering as per the guidelines sometimes becomes challenging when we are practicing, particularly in the Indian context, where cost comes as an issue. Where if we are ordering for stress testing bar some stress echo, which equally costs another 10-15, and when it adds to the thing at one end, that makes the patient uncomfortable, and equally I believe raises questions as well as to why these many investigations, and is the doctor not comfortable or confident enough in making a diagnosis. So that is how equally I look at it. So if unless doubtful about this thing, that is also to come to the conclusion better. Yeah, not to rush as well, but equally patient sometimes I feel are restless in coming to one conclusion, and when we add order too many investigations, we can tend to lose confidence from there. That is how I look into it.
Thanks, Praneeth. You did mention about cost. I think the another important aspect of cost is the fact that many of the patients whom we see, I mean, India's insurance system is a bit screwed up. We most of the insurance companies, be it private or be it state sponsored,
Dr. Anu,
they
can
yes sir. Yes sir.
Answering to what Dr. Praneeth said, a patient has a classic angina. That symptom with an angiogram it is more sensitive and more specific than any functional testing that is available today. Be aware of it.
Absolutely, sir. Absolutely. Person who have got angina, they are telling. Sometimes we do order stress test mostly for not for the diagnosis but for the risk assessment standpoint. So there are different utilities, but for the diagnosis of coronary artery disease, definitely if a person has got angina, there is no role of stress testing there. We were talking about the cost aspect of it. Most of the insurances, they tend to favor supporting a patient when a patient is admitted or getting a procedure as compared to outpatient therapy. So if you have a patient in the Indian scenario where you are contemplating about cost, now remember, this is a cardiac problem. You're not dealing with knee pain. So here, cost certainly, unless you are doing fancy OCTs and whatnot, cost certainly should be one thing that that should be a second thought at this point. But one do need to put this into account, that when you do an angioplasty to a person who is privately insured or who is state is insured, most of the time that patient does not pay for that therapy. Versus you compare it with a 3-year medical therapy burden on that patient, while the 3-year outcome would be more or less the same, the 3-year medical burden is for most of the time patients out of pocket as compared to that stenting. Again, in the scientific world, that is not the justification of doing an angioplasty. But when we are talking about in our patient subset, then then it will be, I think it will be unfair if we say that we shouldn't be looking into these aspects as well. Not to say that they should be driving our decision, but they certainly should be one of the things to look into when we are talking about it. Having said that, I'm just looking for other people for their comments. We have Dr. Shoaib with us. Dr. Shoaib, are you able to hear me? If you could unmute yourself. Dr. Shoaib, are you able to hear me?
Hello, sir. Good evening. Yes, sir.
Yeah. Dr. Shoaib, if you could please give a brief introduction. Who are you? And then tell us what you are, what is your impression about the current discussion that we are having?
Sir, I am a second year cardiology PG from Osmania Hospital, sir.
And what is your thought on the discussion that we are having?
Sir, as far I have understood that, but based upon guidelines, if patient is is having chronic stable angina, based upon courage and ischemia result, there is no mortality as well as morbidity benefit with intervention strategy compared to medical strategy, sir.
Absolutely, Dr. Shoaib. I think what you are pointing is absolutely correct, 100%. There is no doubts about it. Let me also remind you that knee replacement has never been shown to improve mortality or morbid or ACS for that matter. Knee replacement is also not associated with longevity, but still guidelines do recommend doing knee replacement in patients with osteoarthritis. So we as a cardiologist shot in our own foot about 30 years ago when Duke started the large scale evidence-based medicine, medical trial and all this, and where we ourselves said that we will stick to our holy grail and use longevity or mortality or MACE, as to speak, as our clinical endpoint for all the trials or all the studies that we do, not realizing that many of the times the endpoint doesn't just have to be longevity. A person living for 10 years on the bed versus a person walking around for 5 years, those are two different aspects. So knee replacement is done for that reason. So you're absolutely right. A stable angina, medically managed, if you do a single vessel angioplasty, which is not a proximal LAD or left main, it has not been shown to improve longevity or ACS. But here we are talking about things beyond that. We are talking about angina control, lifestyle, and whatnot. And that is where I think the discussion is. Dr. Praveen, you are unmuted. Do you have something to add on this? Praveen, you have something to add? Okay, maybe you are unmuted by mistake. Anybody else has got any other thoughts on this controversial topic where I'm pretty sure Johan sir said that 8 out of 10 such patient will get angioplasty. I think all 10 out of 10 will get such angioplasty. But still we talk about.
Sorry to disturb, sir. Actually,
Yeah.
the voice is very low, sir. For that matter, I unmuted.
Okay, I see.
Anup,
My what
Yes,
you
sir.
call internet speed is fine, sir. But somehow, whatever you have discussed after the you have asked Shoaib, it was comparatively very low. So that's why I unmuted, sir.
Yeah, no, I think today
Anup,
my internet is wrong. Somaraju sir. Yes, sir,
I
please.
just wanted to say to what, continuing on what Dr. Shoaib said, one must realize the limitations of evidence-based medicine and randomized clinical trials. It doesn't answer most of these trials don't answer the question you face on your individual patient, and be aware of it. And randomized clinical trials and evidence-based medicine can be very, very misleading if you blindly try to apply them. I just want to emphasize it and leave it there.
Perfect. Thank you, sir. And in fact, if somebody wants to talk about evidence-based medicine, we can chat offline. I came from a world where almost everything was evidence-based, to the point where somebody did a fake trial of two people jumping off the airplane, one with parachute and one without parachute, asking this question whether parachute helps or not. I have that trial link with me. If somebody is interested, I'll show you. And I don't think you have to guess what was the result, where two people jumped off the plane, one with parachute and one without. But that is the fascination of evidence-based medicine in the Western world. While I don't criticize that, one has to understand that they cannot be applied blindly, and we do have to learn how to apply evidence-based medicine in our real life. So having said that, it's 8:33. I'll go with the closing. If anybody has any comments, they can share here. I'm looking for if Dr. Johan is with us still. Okay, maybe he stepped out. Okay, Dr. Johan, I can't see him. Dr. Srinivas Raju, if you're able to hear me, could you just give your overall closing summary on what we have discussed, particularly my rant on defending why I have a low threshold of angioplasty in these kind of cases, considering all the evidence that we have got, and particularly about the discussion that Dr. Somaraju said and others. Dr. Srinivas Raju, if you could just give a brief summary of this.
Right, Dr. Anup, just as what Dr. Somraju sir has said and what was inputs were given by everyone, definitely we have certain guidelines where CABG or PCI is useful, like left main disease or a left main equivalent or multivessel CID with a LV dysfunction. But again, we have a subset like your patient wherein it was a medial AD lesion, not a proximal LAD lesion. Here we can't apply guidelines all the time, and yes, if we have some idea about the anatomy other than just the say a discrete lesion, like if it is a calcified vessel or vulnerable plaque as was discussed, but again that wouldn't be known from the angiogram, and your patient is already someone who has retired from government service and is a government official. So considering that he has cost constraints, and in this patient, definitely yes, I would think about an angioplasty. Otherwise, if he is someone who is going to be followed up closely, who is likely to take medicines, who is well educated, and who is likely to come for regular follow-ups, then we can still wait on medicines, and then if need be, they later put him through a stress evaluation and then think about a revascularization. So we can't have the same strategy for every patient.
Thank you so much, sir. And I think that should be the take-home message for coronary artery disease. As simple as it looks, it's just a stent, it's just a stenosis which needs to be stented, but probably coronary artery disease is the most complex disease that we as a cardiologist see. And discussion like these, we do need to continue. Praneeth, your closing comments on the session, and then we'll be done after that.
Yeah, it was a good session, as you rightly pointed, commonly faced day-to-day problem, and quite confusing sometimes to make a decision, and you also tend to get question whether you are taking the right decision or not. And at the end of the day, individual patient, individual doctor, and individual decision based on the needs of the patient. If possible, try to discuss the ifs and buts of case, and ultimately the treating doctor will be the right person who will be making the decision for his patient. So uh, evidence-based medicine is yes there, but given patient, we need to blend it according to the needs. That's what I could take from the session.
Thank you so much, Praneeth. Just one last thing I want to add, that while most of the cardiologists, we do know that stenting a stable single vessel disease does not improve longevity or mortality. But patients, on the other hand, they do believe that getting stents means that they are reducing their chance of MI or death. So while we know the data behind it, in those subset of patients where we do think we are doing stenting for symptom relief, it is equally important for us to explain to the patient what we are doing, that the end result of this stent is not improved longevity or MI, but it is symptom relief rather than anything else. So having said that, I'll close the session. Thank you all for attending today's session. To the attendees, we would like to get your feedback, particularly if you're joining us for the first time. If you found the session worthwhile, may we request you to please share it amongst your colleague. Since the general motive is thought sharing amongst us, we host this session every Wednesday. Yeah,
Hello,
Praveen. Yeah.
sir, sorry to interrupt. Sir, please kindly upload all the previous sessions, sir.
Yeah, I am pretty lazy on that, but I promise you in the next 2-3 days, we will get all the sessions uploaded on both podcasts as well as YouTube. You can search there as the Weekly Huddle. I promise you in the next 2-3 days,
Yes,
I'll upload all of them.
PGs from Usmania, they are interested in to hear the previous, so kindly upload, sir.
I will do that. There are already about maybe 15, 17 sessions already there, maybe 20.
27 sessions are there, sir. Last 8 sessions
27
to be
sessions are
uploaded.
there. Yeah. So 27 sessions are already online. If anybody is interested, they can go back in time and start watching through it. Remaining, I will get it uploaded pretty soon. Thank you so much, and good night. We'll see you next Wednesday. Thank you all.